So it's been a great session so far, but then there are always lots of questions, and it has been a very intuitive and a very astute audience. So we've kind of tapped out of most of the questions, but nonetheless, think of this round as a round of free association. Let your intuitive answers and questions come along. We invite questions, we invite comments. To start with, I would invite all the faculty members to please come and take their places on the dais. Dr. Gangadharan, Dr. Mona, we have Alka, Malay, we have Dr. Dipti Shah, and Dr. Kirsi, I think, is on his way, I believe. So, please, sir. I think that's your phone.
Oh, that's right, I think.
So, please, have a seat. Dr. Kirsi is on his way, I believe, right? He is not, yeah, okay. So, we've had a lot of back and forth and questions, but probably there are still some more, and this can go beyond a little bit about the immediate topics. We in general can talk about yoga, spirituality, etc. as well, and the whole of child psychiatry is open for debate. We have our panelists who have their own areas of expertise and their own observations, and of course the floor is open to everybody to chip in as well. We can take questions from the audience, the same format. You get up and introduce yourself. If you have social anxiety, you can write them down and send them across to us, and we'll read them out for you. Anybody wants to set the ball rolling? Oh yeah, of course.
Dr. Mona, I've been wanting to ask you this question for a long time. You talked about the role of the school and the parents in helping a child with anxiety. What about the role of siblings and the religious leaders or the community leaders in helping children with their anxieties?
That's a great question, and it's actually one that we've started talking about, because historically there's not a lot of incorporation of siblings into the treatment. And actually, and so we've been getting a lot of questions from the parents, actually, also of including the siblings. Because it ranges from the siblings, oftentimes what will happen is we treat the patient and the parents then say, oh, now I need to bring the sibling in for treatment. And so it can range from the sibling having kind of a similar problem to the sibling being kind of very high functioning and being able to be a support. And so, so it's something that we've actually been talking about. Do we create a sibling group? Do we incorporate them? Sometimes they'll bring the sibling into, we have what we call family meetings, and we'll bring the sibling in and incorporate them in that. But I mean, I think it's a very important question. And similarly, so the U.S., what we are finding is that there are some families who come in where religion is very important, and attending church or attending kind of their kind of religion is, and so they will look to them for support, and it's more about the community, and it's about kind of getting that kind of support from the community. And so again, that's one that when we kind of think through the more holistic and community-based, I think it's very important to incorporate those pieces in.
Dr. Gangadhar, if I may ask you a small question. You did briefly allude to a few studies about anxiety, but in general, intuitively, anxiety seems to be the most apt illness for yoga to address, because they're essentially the precise mechanism of anxiety. So, the evidence apart, I know you mentioned multiple times that there's a dearth of evidence, but evidence apart, what are your personal experiences with patients with anxiety disorders, and how do you think yoga really helps them a lot?
By far, the strongest evidence for yoga is in anxiety disorders. People have done some studies and have used it, And I told you these GABA mechanisms are all supportive of effects in anxiety disorders. I have to tell you one very interesting comment made by one of the patients. This person was a management expert in one of the IT companies who went through yoga as a treatment in our yoga center, and he was getting better and with anxiety disorder. The comment he made was, look, doctor, I went through some therapy, it was working, and it's one-to-one therapy, and you professionals won't have time. One-to-one with this will be a lot of time investment by you, and naturally you charge more also. It's not cost effective. He was talking like a management person. And in our yoga center, after the first 1 or 2 sessions when they get personally trained, subsequent sessions of yoga will go on in groups, 4, 5, 6, 8 people, and one therapist doing it. So he said yoga worked very well. Wouldn't you think that yoga is cost effective? One therapist is doing it for 6 or 8 people at one session. That was an angle which hadn't applied my mind, honestly. It was some management tech who had to give me that idea. I have a feeling that this is another angle which could be relevant. Yoga in anxiety disorders is helpful. When we have a patient with anxiety disorder in the clinic, if not all, some of us tell them that you have options of either getting yoga, getting psychotherapy, getting drugs, and case to case we may want to give in combination. There are people who have volunteered to take yoga, particularly a lot of literate people who are in the software industry, they opt for yoga.
Any other comments from any of the speakers? Any experiences with anxiety and yoga?
I think in our country now, yoga has been accepted at a very large extent. So whenever we suggest yoga therapy, parents, children, and even adults, they're very happy about it. Most of the other things that we tell them, they would probably, whether it's medication or anything else, they would probably not be so open to it. But yoga is something that they're very open to. So I think it's something which I suggest to each and every patient of mine, be it anxiety, be it depression, be it even psychosis. Yoga, asanas and pranayama, I think, doesn't cause any issues in any kind of a mental disorder. So that is something which I think I apply as a universal therapy for all of my patients, and it really works very well.
I'm glad you asked that, because I was just going to ask Dr. Gangadhar about the potential side effects of yoga.
Side effect was alluded to in my talk as well. I believe there are side effects. My teacher used to say, if a treatment has to be effective, it should also have side effects. Treatment doesn't have side effects is unlikely to be effective. It's in a very at the extreme end. But I believe there are side effects. But I think the art of prescribing yoga depends on identifying those who potentially will develop side effects and prevent such things to happen. Like the case reports of some of the, in quotes, side effects of yoga are quite a person having had a compressed fracture of the vertebra in doing Paschimottanasana, person who have had a dislocation of the spine in the neck when doing the head standing posture, a person who has had a tear in some ligament in one such posture. Like that, people have gone on. It's mostly musculoskeletal side effects that have been described. Whether psychiatric side effects are there or not, except this one case report which I have talked about, psychosis having gotten exacerbated following meditation. But yoga, does it do it? I'm really not sure. Seizure, a non-musculoskeletal symptom, an episode having occurred while doing this have been described, but I don't know whether these should be really called side effects. But I think it is yes, for our understanding it is side effects. But a careful practice of yoga prescription could probably reduce the numbers of side effects.
Is there any kind of phenotype or any kind of group of patients who are more likely to respond to yoga as opposed to anything else?
We don't have at this point of time. Very recently, you must have seen an article in the Indian Journal of Psychiatry. AIMS group of people have talked about one of those phenotypes, genotypes, which is possibly responsible. But in clinical syndromes, which group will respond, which group will not respond to yoga, we need to collect a lot of data to be able to talk about this. Right now, it's too premature to talk about what are the predictors of yoga response.
If I may.
Sure.
If I may add to this, the discussion that is going on in yoga, we have, most of us, at least who are working in the private sector, have our OPDs and all. We also have a lot of consultation liaison base. We interact with other specialists, neurologists, gastroenterologists, cardiologists. Many of the disorders which they diagnose and some of the disorders which we call as psychosomatic have a very substantial component of anxiety or at least emotional dysregulation, which is either which is one of the causative factors for that disorder or keeps on maintaining the disorder. For many of these, addition of a yoga regimen helps them quite a bit. I would not say complete symptomatic relief, but quite a bit of, let's say, emotional relief is experienced by these people. Having said that, they need to go to a proper trained person who knows what he or she is dealing with. Because in our country, maybe elsewhere also, anybody can be a yoga teacher or a yoga guru. There are no qualifications, there is no MMC registration or anything like that. So we need to be a little bit more careful. The second point that I'm going to make is based on the first one. I have a patient who has got a long-standing panic disorder. And like many patients we encounter, this patient doesn't like medication. He would like everything else which is not medication. I don't take medication because my neighbor told me that all the medications are sleeping medications and I will become habituated and somehow my kidneys will fail and all those kinds of issues. But any advice which is non-medical is lapped up very quickly by him and his family. So now for the past 2 or 3 months, I have sort of convinced him to stick on to a small dose of SSRI and maybe a very small dose of, let's say 0.25 or 0.5 clonazepam, strictly on SOS basis. And if that SOS basis comes, he has to first inform me and then take it, that kind of thing. So only on one medication. Now somebody in this 2 or 3 months told him that he should be doing pranayam, right? I would not name what kriya that was, but then it involved a lot of fast breathing, right? One of the problems with that is there is a rapid carbon dioxide washout. There is a temporary state of alkalosis and which can by itself precipitate a panic attack. And he had that. And for that attack, he was put in an ICU for 2 days and all the possible things leading to an angiography were done. And fortunately, the family members had the presence of mind to at least call me once and see whether it is actually something going wrong with his cardiovascular system or it's just precipitation of the existing panic disorder. Everything was fine, so I had to tell him that the only advice that time was, please continue my medication. Like as sir said, everything has a side effect and what you're experiencing is a side effect of that particular practice which was unsupervised and unwarranted. So yes, everything that has an effect has to have some side effect because I tell my patients this all the time, that whatever we are doctors and yes, we have spent so many years studying and practicing and all, but at the end of it, till date, till now, as around 5:15 p.m. on 9th February 2019, medicine remains an inexact science. So we do not know the etiology of any psychiatric disorder completely. Some we know more, some we know less, but not complete. And only when the etiological understanding is complete can we offer a complete treatment. So till that time, whatever we are going to offer is going to have both plus and minus. Even if I'm going to tell you to drink 8 glasses of water a day, there is going to be a problem in some people, right? So based on this, if somebody is really understood yoga and is applying it as per the patient's requirement, that's a good thing. But that often, that would happen in Nimmans because that is quite supervised, structured, and they have got the protocols. But it doesn't happen so often and so well outside.
I agree completely. In fact, am I audible? So, in fact, the same experience that Malay had, I had had with 2-3 other patients. I'll be candid enough and call a spade a spade. It was Kapal Bharti, which probably precipitated that kind of phenomenology. And the almost identical scenario. So what happens is, unfortunately, like with everything else, yoga also has its benefits and disadvantages. And unfortunately, yoga therapists are not yoga teachers. They are therapists. They are know-it-all. Yoga is the Brahmastra. So that can become a little challenging sometimes. And we need to use a little bit of caution and a little bit of discretion in terms of where to apply and what. You had a comment in first, and then I'll come back to you. Can you please give a mic? Yeah, thanks. Please introduce yourself.
Hello. I'm Dr. Deepak Rathod from Kalyan. We have been using yoga in our practice since last 30 years. We have a dedicated hall for yoga. And in between, I had employed some yoga teachers. But myself and my wife, we are both trained in Bihar School of Yoga since early childhood practically. So again, the same discussion which is going on, I agree to that. Yoga in India is too generic practically. And we have relied more on the simple yogasanas and my practice is 80% anxiety, minor mental illnesses. I don't get a lot of psychotic patients that way. Somehow it has built like that. So, as we start, suppose we start a ECT facility in our center, we have certain protocols and certain infrastructure for that. In the same way, if somebody wants to start yoga therapy center, they should have certain infrastructure and certain protocols. And if they are appointing some subordinate or some delegating that work to certain teacher, the teacher should work according to our guidelines. Many times it happened that the teacher was conducting the classes outside and they were telling that stop medication and come to my yoga classes. Like that should not happen. That's why that clarity should be there. It is very effective, but then we have to frame certain protocols for that. And most of these you have already discussed.
Thank you.
I am Dr. Arun Marware. I don't have a question. I have just a comment related to Rashmin's question regarding side effects of yoga. Recently, while reading about mind-body medicine techniques, which include meditation, relaxation techniques, CBT, and so on, some people include even yoga. So the literature says that meditation, yes, certainly it has certain side effects. Around 17 to 21% of the people doing meditation, they have anxiety, predominantly anxiety, maybe panic, maybe a sense of feeling isolated. Many times they have palpitation and so many things. Regarding this relaxation techniques, a few, but less than meditation, may experience anxiety symptoms. But regarding yoga, there is no literature available. That's what I wanted to say. Thank you.
Thank you. Yes, please.
Myself, Dr. Jyotik Bachej from Ahmedabad. I would like to share my experiences with Dr. Mallai sir and I think Dr. Rashmin sir. That initially techniques like rapid breathing, when panic episode or panic disorder patients are there, they definitely feel that my panic episodes have increased in not only in the frequency, but also the intensity. So what my experience is that I design a protocol and for them, that first of all, whatever techniques you are following regarding your pranayama techniques or maybe Kapalbhati or any other, try to keep that on a hold and let us be more scientific in the treatment, let us start with the pharmacotherapy first for 2 weeks. And once that anxiety symptoms get settled, then gradually resume your techniques, and results are better with that, because that's why I asked the question to Dr. Gangadhar sir initially, that whether you start the yoga therapy right from the day one, because that's what I have difficulty which I have been facing in my practice, that day one yoga and these techniques are really challenging for acute episode patients. So kindly share your views, sir, please.
No, there is no two opinions that in an acute condition, I'm not going to ask this person to do it himself. As schizophrenia, acute schizophrenic exacerbation, patient with a manic syndrome, acute mania, no. But in a host of depression, anxiety, obsessive symptoms, where the situation allows yoga to be introduced. My recommendation is it should be introduced. At the same time, I am also cautioning there are a lot of situations wherein drugs may not be necessary in the first encounter. That decision of when I can withhold drugs, not that I should withhold drugs. I should withhold drugs is a different issue also. But we, having been trained in medical practice, we are trigger happy. The trigger is writing a prescription. Whether we should hold any restraint on this writing prescription to every patient whom we see in the clinic is something that we probably have to think for ourselves. I have no rules for this today. But if I go by the guidelines, if anxiety is presenting in the clinic, okay, you prescribe benzodiazepine. Depression, whether up to what level can I tolerate not prescribing, is a decision that is very difficult, it is very sensitive. I know today's world is, particularly in the place where I am working, at least in general practice, a lot of you have been, and your patients are asking yoga or such psychotherapy or listening, etc., etc. Whereas here, prescription is almost always given to every patient.
So should a yoga therapist be a part of the treatment team, sir, in the future?
Yoga?
Should a yoga therapist be a part of the treatment team?
Yeah,
Like
this
say
is
you have
one,
a psychiatrist, psychologist, an
this is one
occupational
thing
therapist.
I raised in one of the psychiatry meetings. The DMHP team, the District Mental Health Program team, has psychiatrist, a psychologist, a social worker, and a nurse. This is the 4-member team. Now, I think the days are not very far off when I'm going to be talking of a yoga therapist in the team.
So something that you said struck me. So when you said anxiety and kind of benzodiazepine, and because I agree with you completely, it's what is the role of medication? And one thing that we're learning, right, again, this is all an animal model, so it doesn't translate well to humans, but we know that in animals who are undergoing exposure therapy, when a benzodiazepine is introduced, they are not learning from the exposure therapy. So they're not coding that new memory, so the benzodiazepine is actually interfering. So while it helps in the short run, it's actually interfering with long-term benefit on the anxiety. And so this is where yoga is very appealing in that it's building that brain function, right? It's building that attention, so on multiple levels, it's the GABA, the cortisol, all that you explained, and just kind of the way in which it's impacting kind of even the brain in a very different way from how the medication engages. Just makes it very compelling.
Yeah, I have to make a point. Sorry, I mean, whenever we talk of yoga, prescribing in the clinic, the general image is that it's a therapist who is teaching yoga, and it has to be maybe 2 to 4 weeks of training, and every day he has to come, and it's for half an hour, 45 minutes, he has to give that time to practice that yoga. It's so overwhelming, nearly all patients refuse. Example, in a trial of schizophrenia where the consent form was very clear, that yoga will be taught by a therapist, 45 minutes a day, you have to come for 3 weeks for training, under supervision, you have to practice every day at home. It was so overwhelming. Out of 1,026 patients who were interviewed, about 80 people accepted the trial. So my observation from this is that we need to present yoga in a way which is palatable to them. In fact, we have one a very young person who has done MD in yoga. He has been talking about, can I prescribe yoga as an outpatient? Can the doctor give some simple yogic things right there? It could be 5-10 minutes procedure. And he did, he told me one experience of his wherein a person was brought to the yoga center where he was practicing. This person got stuck in the lift while coming down. And after about 10-12 minutes, the lift was brought down. And she came out, she was a IAS officer. She started panicking. And by the time she reached her office, because she had to come and put the thumbprint, she was in such a panic, and all her bosses, all her friends, colleagues, joint secretaries, etc., were about to shift her to a cardiology center because she was so anxious and she was so having palpitation and she was sweating, etc., etc. And it just happened that this man was there, and he said, why don't you sit down in this room, I'll teach you something. And he taught some 1 or 2 breathing and om, whatever it is. And by afternoon, she was feeling better. By evening, she was much better. So he was, this man keeps telling me that we must think of some simple OP level practices which can be first aid and it can get better, and not conventionally thought of yoga as something that you have to learn for days, months, years. And in fact, yoga therapies, the yogis, those who are going to be talking about yoga, do not believe in this short-term business at all. They always think, in fact, all our trials have had serious criticism by yogis. You are trying to look for a change in 7 days, in 3 weeks, in 3 months. No way, that is not yoga. I don't know what you are doing. This is not yoga. So I believe maybe they have a viewpoint, but I think from a pragmatic clinical application, we have to tailor it to something that can be prescribed off the counter.
So many patients come to us for stopping medication, and they say, we want to do yoga. The first question asked is, what is exactly yoga and what yoga should I follow? For example, Hatha Yoga, Patanjali Yoga, Bhakti Yoga, and most known is Raj Yoga, because all this is seen on TV. So now it is very difficult exactly what is yoga, what should I advise for these patients, whether it should be supervised, how long it has to be done. So it is how you convince your patients that this short form of yoga or whatever you recommend is going to help him, and how you convince them about doing this yoga.
I'm clearly not an expert on yoga. Dr. Gangadhar is well spoken, but I think the types of yoga are probably like choosing between Serta, Daxit, Surlift.
May I?
It's just a brand.
I
right?
want to interrupt.
May I mean, if a query comes like that, it's better that we don't, I mean, at least what I would do is, I would not tell them that you do this yoga and that yoga, but I'll tell them that certain yogic techniques like ABC may work, right? Because when we need to prescribe yoga for something specific, then we need to be specific ourselves. If you're going to teach them simple breathing relaxation exercises, then we'll say it's a yogic way of relaxation and that's it. If you are a trained yoga teacher or a therapist and you know some things more about certain asanas or certain other techniques which have been useful, well, we'll be able to tell them. And that's why from NIMHANS we have these protocols. Yoga protocols for schizophrenia, for depression, for ABCD, XYZ. There are quite a few of them. So I would not tell them that go and do Raj Yoga, because the problem is I don't know what it is. Or I would not say do Ashtanga Yoga, because it is difficult for everybody on earth to practice that Ashtanga Yoga. In fact, just on the flip side of things, a lady had come to me because she was experiencing certain difficulties. I mean, most people have a difficulty with their life partner, so some interpersonal issues were there. On clinical assessment, there was there was hardly any anxiety or depression, only the day-to-day arguments and stuff like that. And she tells me that, I want you to prescribe me some yoga so that I'll be, I mean, the problems with my husband would be minimized. Now, well, there's no answer to that. So I told her simply, I'll prescribe only one thing, that both you and your husband should do a Shirsasan, that's a headstand, and then try and argue. See if you can open your mouth and talk. So sometimes it borders on the silly. So basically the idea is not to really put your foot into it. See what techniques have worked. What evidence we have from yoga studies is not the comprehensive yoga or yoga as a lifestyle. Certain techniques, right? So I think it would be better if we tell them that certain things can be practice of the whole thing.
Can I just, taking a leaf from all of that, I think we can learn from schools. Schools have very effectively integrated yoga, simple basic asanas, and some meditation and breathing techniques many of the schools are following. So much so that children actually look forward to it. I've had kids who say, you know, my bus was late, I missed my meditation session and I really didn't like it. So things like this, which is a very positive way of looking at it, and their techniques and whatever they're following, they have yoga teachers because they have yoga as a subject too, which the child can opt for. And they teach them simple asanas, which everybody from like first grade to 10th grade can do and does on a regular basis. And I think when it comes to economics, cost effectiveness, vis-a-vis a life skills program, this is something which is really going to be very, very effective, and we should honestly encourage that.
True. I'll just take this opportunity to welcome our colleague, Dr. Kersi, who was detained at another program in the same context. So welcome, Dr. Kersi. And a brief housekeeping comment. The URL which IFSIT requested all of you to log on to and answer a few questions on a simple Google Doc questionnaire, we have converted that into a QR code. So if you are lazy or dyslexic, you can simply scan it and probably answer those questions, and that would really help us gather information to help you better. So moving on, I think we did briefly allude to school refusal as one of the, sorry, somebody had a comment? We won't ask you to introduce yourself, we know who you are.
Okay, the devil's advocate. Yoga has been known, is around for 5,000 years. And it is a part of the Indian culture for ever so long. Still, Indian population preferred allopathic medicines for anxiety and depression. Then suddenly we had a political sort of push or boost to yoga. Newspapers talked about yoga, and now yoga seems to be almost the elixir of life. So how much of this is culture? How much of this is science? How much of this is popular belief? Or is this simply a pendulum swinging for wanting lasting quick relief? We have a society, till about 10 years ago, we used to talk of doctors being pill prescribers or pill pushers. But at the same time, we had a pill popping society. If a patient goes to a doctor, the patient wants a pill. A colleague of mine from Mumbai shifted to Sholapur, and he said in Sholapur, if you don't give an injection, you are not a good doctor. So how far are we being dictated by popular beliefs, by the media, and true science or the skills and art of controlling anxiety or our own emotions without taking a pill?
There was a point where we were taught relaxation therapy as a part of our postgraduate training. So I think the Beck's relaxation techniques that we all learned and used to actually administer on our patients as postgraduate students, now probably as consultants we don't have the time to do that, but that's essentially quite the same as some of the yoga exercises, right? I mean, so it's...
If we follow the television, a couple of years ago, out of the blue, we had a gentleman who used to give these yoga lessons for everyone, including schools. He used to tie himself into knots, which most of us don't. He eventually became an industrialist. So there is prosperity in yoga or yoga preaching. It's very few, if we really look at psychiatry literature, besides Dr. Gangadhar and his center, not too many publications or research on science of yoga. So how far are we? It's just one. Why have I been wanting Dr. Gangadhar to come and talk to us about yoga? Because there's nobody else capable of delivering what he delivered. So is this a kind of science that is not recognized? Or is this something that we are missing?
When I joined psychiatry, as soon as my MBBS course got over, some of my classmates who had to make a comment, "You're joining this course, you have no prescriptions to write." So the doctor has to have a role of writing the prescription. This is the image that all of us had. And he told me, "You're going there, you won't have any chance to write any prescription." This is one part of it. Writing a prescription, doctor equals writing a prescription. Or use a knife, where you don't have to. Barring this, there is something else that these doctors can do, is something never taught for a long time. Let's accept that. All of us have had this issue. This is one component of it. The second thing is the push that it got, let's say 4 or 5 years back, is one thing that yoga became very popular. Yoga, I wouldn't say yoga became popular, yoga got the pride of place. But even before that, if you look at the literature, science of yoga, even in mental health, there were more from outside India than within India. This is something that we all have to get really concerned. There will be one day we will have pharmacopoeias of yoga published by maybe APA or RCP, which we will be adopting. Nice guidelines has to include yoga as a form of therapy, and none of the ICMR, none of the IPS guidelines have included this. Yeah. So the trend has already come. I'm not saying, I'm not being fanatic about yoga, but the point here is that there has to be an objective look at this procedure before we think that it is irrelevant. For all along we have been saying it's irrelevant. All I'm trying to say is, let's be objective, let's be open and see whether there is a role in this at all or not. And when this happens, maybe it will come back. When I prescribe yoga, to ask a patient to do yoga, the first common answer is, no, there are a lot of yoga schools, I will do there, I don't have to come here. At the other end, the yoga schools are, every road now has some yoga classes being conducted, something will be there. They will be doing yoga for overall wellness of people. Good experiment, good input into the society, but the fact remains whether they would tailor it to a given condition that this person is suffering, which is not likely to happen. So we realized that a few months back we did a syllabus for yoga for mental health. And we invited people to come and join as a 1-month certificate course. About 15 people applied, and we selected amongst that 15, 9 of them, because there were qualifications, etc., we had to match. So 9 people participated in this yoga for mental health certificate course. These are all yoga teachers, people who have been teaching yoga and yoga therapists. This was the first time this has happened. This is the first time that has happened, at least as far as I know in our own institute. And the feedback by these people has been very rewarding. And they say that, we never knew that some conditions we can tailor yoga, adding this and removing that therapy, etc., and making it very simple. We don't have to make them becoming yogis, but we are making them use yoga for getting better. So this is a concept that we did not know as yoga teachers, people who have been trained in yoga. So this experiment is continuing. The next batch will soon be starting. For those who may want to look at it, the website of Nimhans, Yoga at Nimhans, keeps featuring when the next batch will start. The first batch was very encouraging, and already people have been contacting us for the second batch. We will try pushing this a little more, sir.
So
Just devil's advocacy again. Ayurveda, Unani, or even the whole network of faith healers did not recommend yoga. They blamed the, they blamed
Ayurveda does.
Sorry, sir?
Ayurveda does.
Ayurveda does not, as a regular treatment or as add-on to the medication.
I have to look at that.
So, just a moment. As an extension of the same discussion, I have a question as well as a request to make. Is there any need that you see of psychiatrists who, I think most of us are sold on the fact that yoga has a tremendous amount of benefit for our patients and for various conditions. Do you think psychiatrists should get some basic level training in yoga to be able to appreciate and understand the benefits of it, and to take it a step further, maybe you at Nimhans or some other people who are like-minded are willing to work with you, should there be some kind of a regime that you might advocate? Say, for example, these kind of yogas are beneficial for depression, these kind of yogas are beneficial for anxiety, these are beneficial for, say, bipolar disorder or schizophrenia, for example.
Yeah, we, just as much as we invited yoga teachers for a course, certificate course, we also had invited mental health professionals for a 1-week course on yoga in different mental disorders. So this happened at a digital level, and they had an option to come at their free time for about 3 hours for observation. We have had people going through this course also. Since I was that time out of circulation, I was preoccupied, I cannot give a recount of what their feedbacks were. But whatever I heard was, to them, they were feeling more confident to prescribe yoga, period. But I think, sir, I will take it a point. Maybe such awareness things, more and more psychiatrists would come.
No, I think, sir, we are all completely sold on the idea that yoga has its benefits. But it's, at the present level, to the best of my understanding, very generic. Yoga works, how it works, which yoga in which condition. For example, like Malay pointed out through my own personal experiences, certain kind of yogas have actually precipitated problems rather than solving them. So how? Which kind of yoga? So maybe we can probably look forward to some kind of guidelines from you in terms of disorder-specific yogic exercises? Precision yoga.
Yeah.
One important thing is that, as sir mentioned at the start of his presentation, that yoga is a holistic approach. Holistic approach would mean that we need to look at the person as a whole rather than the person as an illness entity or an organ or A, B, C, D, X, Y, Z. Now the thing here is that if anybody studies yoga for the purpose of studying yoga, not from the therapy point of view, there are two aspects. One is the physical aspect, which is the asanas and all, but there is also a philosophical and a spiritual aspect, and there is a system of things which can also probably with good work translate into an indigenous form of psychotherapy. So here what sir has focused on is two components, but there is a lot more to yoga than only, it's basically a holistic philosophy which is going to focus on the human being as a whole, the psychological aspects as well as the physical aspects. So right now when we are prescribing or there are certain guidelines or protocols, they are basically targeting the physical aspects of the yoga. The sutras on which the whole system of yoga is based, it's a totally different ball game. So that brings us to the point that you make, should psychiatrists learn yoga? I would say yes. Because like many schools of understanding the various etiologies of psychiatric disorders, this is one, our own indigenous way of looking at things from a different perspective. And so it offers us two things. One is the physical forms of therapy as well as the psychological forms of interacting with other human beings and stuff like that.
There you go. Now you know why he's sitting next to Dr. Gangadhar, right? There was a reason for that. Mona.
And I'm really interested by what you said, though, right? That by integrating it into the schools, the children are growing up integrating this into their lives. And so it becomes a way of life, right? And what I'm wondering is, this developing brain that's getting exposed to this, now all of a sudden vulnerabilities are being addressed in a very different way, right? So you talked about the GABA, the cortisol, right? So if these levels are altered as the brain is developing, is that going to add resilience, right? And then lower the need for medication because the biology is being taken care of in a more kind of developmental way.
So I think you already have 2 arms ready for any studies which child psychiatrists should take up.
It would be amazing.
Yoga being taught in schools versus schools where they don't have yoga, and maybe you can do an epidemiological study in terms of the differences in the incidences of developmental issues or behavioral problems. There you go. I mean, the arms are there, the candidates are there. I think the researchers are the ones who still have to be recruited. It's the other way around this time, right? Any comment?
Question to, I would ask Dr. Gangadhar sir, because we have a Ministry of Ayush in India. Is there any working group or some work done to regularize this yoga therapy and other things for guidelines for this as per, from the government side? Because there is a ministry for that.
Ayush, is a separate department of yoga, and now there is a separate ministry as well in the Ayush. They are, one of the focus is integrating Ayush into mainstream healthcare. But they of course are encouraging research on yoga and mental health. We also received 1 or 2 projects, and many people have received some projects. But whether they are having any mission for integrating yoga in mental health per se, I am not aware.
So can yoga be as a preventive rather than therapeutic? Like Madam told about in childhood or in the schools they are practicing yogas regularly. So it can be used as a preventive measure in the mental health rather than therapeutic. Another questions to Mona Madam about the conduct disturbances, because mild anxiety disorders or these are can be treated by CBTs, but when some patients they are coming with the conduct disturbances, children with the conduct disturbances, severe conduct disturbances, so how to handle those conduct disturbances?
Dr. Mona would like to answer that.
Sir, it's a Herculean task to generate evidence-based answer whether yoga would have a role in preventing several of the psychiatric disorders. At this point of time, with the resources available, I would not venture on doing this as a clinical test or even a research agenda. But if you go by traditional texts, they say if you practice yoga, you will prevent all these things. So let's accept what they have said. Experience-based evidence, not necessarily research-based evidence.
Sir, I have a question based on the the discussion which is underway. That in one of the conferences, I was talking with an Ayurveda practitioner, and I was asking him, because allopathy is evidence-based medicine and Ayurveda is culturally experience-based medicine. So I asked him, like, can you not make that the Ayurveda like undergo the same trials as we do and form the evidence body, and through that can you make Ayurveda more standardized? So he answered me that the methodology that you have devised is made for your science. you cannot apply the same parameter for our science and judge our validity through it, because our science is experience-based science. Now, this is the answer that he gave me, and the question that I want to ask, then how does making yoga courses can solve this problem? Because are we necessarily depriving yoga of its essence by standardizing it and by making it in the form of these parameters and everything?
You'd like to comment, sir?
Any answers?
No, I think we are not standardizing yoga. I think all we're trying to do, or what I should say, Nimhans and Sir is trying to do, is create modules for mental health. We are being very specific. The yoga which is working in our conditions is all we want to comment on. We are not trying to say that these are the modules that one should follow as a yogic technique. Yoga per se is too vast any which ways. At present, all that the focus is on the asanas and the physical thing, right? So this aspect of it to standardize, to quantify, so that the malfunction or the erroneous use of it, where you land up into musculoskeletal injuries or you have side effects which are avoidable, that is all that is trying, I mean, the attempt to standardize is what I've understood. Yeah?
Having had long discussions on yoga, where I started off and then didn't complete, is the role of media on children's behavior. We have aggressive outbursts and we have poor tolerance. Children pick up the news items and mimic them. So we have sexual precocity, we have got aggressive behaviors and intolerance. So we have three child psychiatrists and other psychiatrists who have done a lot of work with children. So the role of media in child development and child behavior.
Dr. Kirsi would like to start.
Well, unfortunately, there's no getting away from the fact that media is here and media is here to stay. But what we do look at is, sometimes one believes that there is an overemphasis on the media and things just get lumped with the media. But there's also no getting away from the fact that the media can, especially in the susceptible individual, cause some changes so that the kid starts thinking that what he's seeing is normal. Now, if I'm giving you an example, say for pornography, which is not really media-based, but if you're looking at pornography, probably the first time a child watches it, he'll be shocked. The second time, he'll be shocked less. The third time, it becomes routine. Just like that, if you're constantly watching aggression on the media, or you're constantly watching promiscuity on the media, it becomes kind of acceptable behavior. And though a lot of our cultures and a lot of our societies may be extremely broad-minded, it's still necessary for us to be aware of the fact that the child is going to discriminate between what is okay and what is not okay after a certain stage. Whether we are psychologically oriented, biologically oriented, whatever it is necessary for the child to develop a kind of a concept between what's right and wrong, rather than just follow what he sees as right and wrong on the media, which seems to be acceptable. I still remember there was this horrific time when a publisher had come up to me and he wanted to start a new series of books. And he said, I'm targeting the first standard. So I said, very good. So he says, you know, we are doing A's for apple and B's for ball and C's for cat and D's for dog. Let's make it more realistic. So I said, what does that mean? He says, let's make it A's for ack guns and B's for bombs and C's for cannons and D's for stuff like that. I suggested he come to me for treatment. The bottom line is, there's no getting away from the fact that media is also extremely market-driven. And this whole thing of, you know, it's wonderful. I mean, when you talk to a media person, he'll say that we give the audience what they want to get from us. I would firmly believe that we need to have some kind of code in which maybe what is acceptable, not acceptable, is a little more rigorously defined.
True.
It's just too easy for us to kind of say, oh, our kids will pick it up anyway. Yes, they will, but why make it easier for them? There's no getting away also from the fact that our kids are becoming more and more shall we say, finding it more and more difficult to concentrate. And there are some research papers which talk about the fact that, if you're constantly watching, say, television, or you're on the cell watching YouTube for X amount of hours, the amount of time that you can spend in actually concentrating seems to be less. So there are lots and lots of parameters associated with this, and I guess we need to discuss it in a little more detail.
Yeah, can I build on what you said? Because absolutely. So a couple of things, right? So around the concentration piece, what they've found, at least in American media, is that when they look at the TV shows, so frame shift is kind of how much change happens in any given second on the TV, and that's dramatically increased over time. And so children are very used to very fast things happening and much faster. And so again, it's passive viewing, and so they're not having to engage in it, and it's being done, and it's very exciting. And so then when you go to the real world, it's very boring. And what I found on our substance abuse unit especially was that, and with our kids with anxiety, boredom is something very difficult for these kids. Because when they're constantly getting that information transmitted in such a quick way, their brain starts processing that, and then real life seems different. In the United States, there's a website called commonsense.com that actually has created kind of I don't know here as well, right? And so they're starting to look at, okay, here's kind of what to look for as a parent. Like, here's some things that might be kind of problematic about the show. And there's a lot of emphasis on if you're going to allow your child to watch something that's beyond their age, then sit down with them, because you want them to learn, right? And so it's not about fully protecting them and saying, no, we're never going to expose you to anything, but how do we have conversations with them about what they're viewing? How are they integrating it and making sense? Because they're going to see it.
Any comments from the rest of the panelists?
We just can't avoid the fact that media is here to stay. Like 20 years ago, Tom and Jerry was very aggressive, very, very aggressive. We had kids clobbering each other because they'd seen it on Tom and Jerry, and Tom and Jerry is a very popular cartoon. So the idea is to balance it out and possibly have a lot of filters for parents, which parents are not aware of, and neither are they willing to learn, and they expect magic to happen. Can I buy a phone with filters in it so that my kid can? No, you can't do that. You have to be educated, and you have to be responsible, and you have to also be willing to put that phone down and give face-to-face time if you want your child to do the same thing. Right? So we have a group of people who are actually working on this, and it's called Responsible Netism. They go to schools and they teach parents, they teach teachers, and they teach children separately about safe zones, safe apps, safe games, safe places to explore digitally, so that you don't get caught into things like cyberbullying and the other things which are side effects of netism. So how we can all be responsible netizens is probably the aim, to balance it out.
So yes, as everything has been said, media is here to stay. Generally what we have observed is parents are proud. I even have parents of 1.5-year-old children who will come and say, ma'am, my child can easily unlock the phone. They are proud of the fact that the child is able to use the phone so well. So I think that is an area where we need to focus on in terms of parenting, how parents can understand media, how they can understand the digitalization that is happening, and how they can safely guide children. So I generally tell them that using a gadget is exactly like driving a car. So before you give your child the keys to the car, you ensure that the child has learned driving, has got a license, and then the car keys are given. So similarly, before you give a gadget, before you expose them to social media, there has to be, kind of a contract, what are the do's and the don'ts, and how they can use the digital media in a better way rather than cause harm to themselves.
So I'm going to put up a very contentious question to almost everybody in the house. At what age should a child be allowed to use a cell phone? I can already see heads nodding and some actually. Yes, please. Can anybody give him a mic, please? Let me just elaborate that question. Not just use a cell phone, but even own one, right? That's the more important one. Use, I think they probably do, like Dipti said, from 1.5 years, they have learned to unlock the phone.
I think I read somewhere that the American Academy of Pediatrics has come out with a guidelines on this. And they do not recommend, if I recollect well, because I read it in the media about this. Maybe Dr. Potter can tell us more if she's aware. That no child should be exposed before the age of 7, if I recollect well.
5, yeah. 5.
5. But at what age should, now there are no guidelines on this, I know, but. Yeah, maybe. But at what age do you think we should allow a child to own a cell phone? What do you think?
Okay, so we've had conversations like this with parents in schools because I've been a consultant to a whole bunch of schools. The general consensus was that you can allow a kid by the time he's about 6, 7, 8, 9, say about 7 or 8 to own a phone provided it's not a smartphone. So it's available for him just in terms of knowing where he is, his parents know where he is and things like that, which is really very difficult. But it works. We were all skeptical, but in this extremely elitist school to which I consult, it works.
Why would a 7-year-old child need a phone? I mean,
It's basically in terms of so that the parent knows where he's going. That kind of thing. Not a smartphone. So you don't have all the internet streaming.
Any other comments from the panelists before I let the audience in?
Yeah, I don't know about the guidelines or whatever, but when my daughter was in the 6th grade or so, that would be 10 years. That was a time when we gave her a phone, which was a Nokia phone, a non-smart one, but it was a properly written contract, handwritten contract, written informed consent to be signed by the child and parents. I still have it at home. I didn't know the question would come, so I didn't get it. But it still is filed and kept. So she used that phone till she was around 9th standard, 10th standard something, because, yeah, the idea was what Dr. Kersi Chawda said, to be able to find out where she is at any given time. Fortunately, daughter turned out to be quite responsible, so we never had any problems, or maybe she was smart enough not to allow her problems to come to us. Now she's probably on her 3rd or 4th phone. She's 19 years old, so pretty much responsible. What I'm trying to say is this, that we are not going to, for a long time, have non-smartphones. They are on their way to obliteration. That is the question that is going to come up to us in the next few years. All phones are reasonably going to be smart enough, probably. Second thing is that whatever we have, smartphones or no smartphones, whatever, they're all going to be they are a part of a child's environment right from day one. And we know that cognitive development, according to the older model of Piaget, all begins with exploration. So the child is going to explore. Now, whether there's a scissor or a knife in the environment, or a cell phone, a smartphone, or an iPad, or whatever, everything is going to be explored. Now, whatever precautions our parents had taken when we were young, not to, knife pakad liya to bhai hold it with the handle, not with the sharp edge. Something like this will need to be done for everything, because everything is in a child's environment. Today's children are digital natives. We are digital immigrants. I would actually like to go back in time and put myself as digital native, because there are advantages to that, and of course there are disadvantages. And I would have liked to see what my parents would have done with me. But the fact is inescapable that it is going to be a part of the child's environment, and the children are going to explore, and we need to allow them to explore, because that is what they are going to grow up with till some new revolution happens in the digital world or otherwise. We need to make it safe for them and not sanitized for them, because that doesn't work.
Anybody else would like a comment about at what age should we allow the child to own a phone?
I think it depends on the child, right? I mean, again, if we think about their brain, especially their frontal lobe, that is decision-making, higher-order thinking, I think for some kids, they're more able to handle the responsibility. They can hear the teaching, and in the moment, they can integrate that teaching. For others, I think it's much harder to do. And so I think it's really going to vary. I mean, there are some kids who I think by middle school are ready, and some others by even high school they're not. Again, if you think about, for example, Instagram, which I don't know, is it here as well, right? What a bad idea or Snapchat, even worse, right? To give an adolescent this, where in the moment you can send something impulsively and it's out. That's very dangerous, right? Again, some kids can think ahead for the consequences, others can't. And so I really do think that there's a range. I don't know that we can say that there's this exact age by which every kid would be ready.
So you're suggesting
but you
it's
should
as
say there's a
contentious
minimum.
as gun control law is, right? No, the challenge is this.
May I ask?
That there is an issue with stimulation extinction, right? That's the biggest challenge with smartphones or any smart devices. There is no extinction.
I think now the focus
on
should
and
move
on
to
and
the
on.
audience.
Yeah, I'll come to you in a moment. I'll come to you. The reason why I'm getting them to commit first is then you can actually challenge us, right?
Yeah.
So,
I am going to ask a challenging question. I am Dr. Dabholkar from Satara. Unfortunately, with both of my sons at USA. See, the way in which we are parenting the children has changed since we were child, and now we are having children and grandchildren. Now we are expecting our young children to be independent and responsible for their actions. And at the same time, we say that up to age of 25, frontal lobes are not well developed, which are required for handling independence, freedom of choice, and being responsible. So we are in a contradictory situation. As a society, we are expecting them to be free, make their own choices, and be responsible for them. But at the neurological level, they are not fit for it. So we are creating a very bad situation for our children. I say the problem of parenting, there are so many choices to make, and they don't know how to make the choice. And then they land up with increasing anxiety and all the things. Your comments, please.
I think that's why we sometimes see more mental health issues now, right? Because they're being asked to make decisions earlier in life that they might not be quite ready to make, and they're being kind of just, there's so many kind of different signals coming at them from multiple different levels, and they're having to handle all of this and still kind of grow and develop in their kind of normal, in the basic trajectory. I think that's a really good point.
anybody else would like to suggest?
Sir, I want to ask question for Gangadhar sir. The definition of yoga is Chittavritti Nirodha, and it is more preventive rather than curative and therapeutic. So it is included behavior, diet and all these things. So in school health, if it is included in the school health, it will be better to change their behavior in the future.
We didn't quite get the question. Can you just repeat that so Dr. Gangadhar can answer you? What is the precise question that you want to ask?
He wants
Yoga is preventive rather than it's curative or therapeutic.
Fine.
So in the school-going children, can it be effective to change their behavior?
The Ayush department has moved a program of examining school yoga. In fact, in the last 10 years, 2-3 proposals have come up. Many schools have started using it, but any clinical trial has happened or not, we don't have any data. But there are several researchers which have shown introducing yoga in schools, some general parameters of education have gotten better. There is one paper I did here where yoga was introduced and yoga was not introduced in another school or in the same school, I don't remember. The school where yoga was introduced had fewer dropouts, fewer absenteeism, overall percentage was higher, fewer events of misconduct, and there's some 8 or 10 parameters they had were able to demonstrate.
I have a question which is not related to yoga or use of phone. I have something different. I'm seeing younger girls or boys of age group of 12 to 14 doing self-harm just to come over their anxiety. Now when they come with the complaint of self-harm and complain of anxiety, their parents and they themselves also are not willing to take medication. They say because this act reduces our anxiety, and suppose if we start taking medicine and that does not reduce our anxiety immediately, we will go back to self-harm. So where is a point in taking medication? What should one do at such times? And the parents are very skeptical about they getting dependent at that young age of taking medication.
Dr. Mona can start with.
So they're related but separate in some ways, right? Because there's the underlying anxiety disorder that you want to decide what the treatment plan is going to be. And then there's that maladaptive coping pattern of kind of going to self-injury. And so, and with self-harm, it's what is the purpose of self-harm? For some kids, it is that kind of immediate response of, if I feel that physical pain, then I won't feel the emotional pain, and so it distracts me. For some, it's actually attention seeking. It's saying, okay, let me show you how much pain I'm in, and you're not hearing me when I tell you, so here, I will self-injure, and that will show you just how deep my pain is. And so part of it is first understanding the function of the self-harm. And once you understand the function of it, it helps you kind of figure out how you're going to tackle it. And then it's again kind of addressing, sometimes parents or children will say, well, what's the harm in this self-harm, right? What's the problem? I'm superficially cutting, it's not a big deal. But what we do know is that research shows us that individuals who self-harm have a higher tendency to convert to suicidality and attempt suicide. And so there is harm in just even in kind of letting it go as the coping mechanism. And so saying, okay, I understand that it works. It's a short-term solution for a problem, and it's in the long term actually going to be more harmful for the problem than it is going to be helpful. And so while I understand that whatever we take, and we will say, what we give you most likely is not going to give you the same relief that self-harm does. It's very powerful in that moment, and so they do have to agree to sit with some level of distress that they will experience once they, especially in the kind of the immediacy of stopping the self-harm, if it is for that kind of physical kind of pain that gives them relief. If it's more for the attention seeking, then it's a lot of teaching the parents kind of the validation, saying, okay, look, your child is really struggling. How can you help your child feel heard, and then help them kind of more productively manage? So again, it's a couple of different. And so then again, saying the anxiety is still there, no matter what, and we do need to address the anxiety. Now, whether it is kind of to the point of medication, or if a more holistic approach, or what the treatment regimen is, I do think that it's kind of in some ways looking at both in kind of as kind of both issues that need to be addressed.
Dipti, you have any comments on it, Dipti?
Yeah, many a times we have also seen this self-harm happening as a copycat behavior. We see that often in a particular classroom. Like I would have 4 or 5 girls from the same class coming to me in about the same month, because that's a copycat behavior. So as Mona rightly pointed out, that we need to get into a little more depth and find out the cause of the self-harm. That is going to be important. But what we generally do is we have a team wherein the psychologist is there, the psychotherapist is there. We use sometimes other techniques in terms of using certain games, those kinds of techniques to engage the children. And those techniques in terms of relieving anxiety, getting a rapport established, and then working with the child at immediate level, what they can do when they get the urge, and what can be done at a more long-term level. Working with parents is going to be extremely important part of the treatment. So it is a comprehensive approach, and usually we see results coming in some time. It doesn't come immediately. But even without medication, we can get results. The only thing is that they have to continue follow-up in terms of the longitudinal thing.
Yes. Despite of counseling the parents, 2 of these patients, their parents are home. So they are children of single parents. Okay. So the single parent problem is also there. Despite of all that, the mother this girl insists on cutting herself, harming herself. There is not an inch of an area on her body where she has not cut, to the extent that she has several times had to go to surgery to get sutured, dressed and everything. But she's totally obsessed about harming herself.
But then in that case, is this an anxiety disorder manifesting as DSH, or is it more of psychopathology of some other nature? That is probably what we need to address, because...
Yes.
So, Casey, would you like to comment on this?
Yeah, actually, I was just thinking about this case that you're talking about, because I've had once, I'm getting a lot of old people also cutting. So what used to be predominantly a child behavior, I'm now actually getting mother and daughter coming in and both telling me they're cutting, which is a little frightening. One of the things that he said quite correctly, given what you've talked about, it's very, very likely that there is something much more than anxiety. So if there is some psychotic thing happening, then we need to deal with that. The other thing that we see over and over again, and I'm not absolutely agreeable with what Mona said in terms of it's an attention-getting gimmick. I'm not very, shall we say, experientially, I don't see too much of that. I would see it more in terms of a cry for help. I would see it more in terms of I'm feeling so numb that the only way I can feel anything is to cut myself physically. I wouldn't really see it as, let me show you, bastard. That's not what I would see.
There is one particular boy who cuts and harms himself nearing his examinations. And he says, I can study better when I cut myself. Now that's something very abnormal, I feel.
Any other experiences?
So you were asking about the medication and the refused, so I think that is where the biological model really helps to show what is going on in the brain with the absence of certain neurotransmitters, and a trajectory that if you don't treat, what can really happen and what can go on to become even more disturbing behavior and more absence of differentiation with the synaptic pruning. Once you explain that model to parents, somehow the fact that the long-term outcome is much worse if we don't treat is something which I've found that they accept. And then they do take treatment. We can always start by saying, we'll start for a short period of time. You always have the option to take it off. You always have the option. But we have to keep trying.
Right.
I don't know, maybe I've just been lucky, none of my patients have ever refused.
I think we have to keep trying.
No, I think probably when you have a repeated cutter or a repeated deliberate self-harmer, beyond a point, I think they become amenable to taking medications because they don't see any other way out of it, right? So they're desperate. They're like, doctor, do whatever you can, but try and stop this. But then that also extending on the same topic, what about kids with impulse control issues or emerging or evolving borderline traits? So how do you deal with those kind of kids? Because I think we see a lot of those in the section of cutters or overdosers or whatever. So how do you think we should deal with those? Mona can start the discussion and then others can pick up the ball.
So actually what you're describing is pretty common in our DBT program, our adolescent outpatient DBT program. I would say that the majority of kids, all of the kids who come into the program are self-injure, and we've seen many kids for whom arms, thighs, legs, abdomen, where just the cutting is kind of the thing that they turn to in the moment. That's what DBT was built to address. It's that, and again, the structure of DBT is first finding what they call the foot in the door, kind of working together to say, I get this really helps you in the moment, and it's not going to be helpful for you in the long run. And so how do we partner together to get you to agree to even a short amount of time where you are going to be willing to not turn to self-injury. But then I need to give you alternative skills in the moment. And that's where the distress tolerance skills actually do come in. We were talking about kind of emotional sensitivity. And a lot of times these kids when they get to that point, especially when there's BPD, borderline personality disorder, they get so dysregulated that in the moment, they're overwhelmed by their feelings. They cannot make the right decision. And so in the moment, it's just about how to lower the distress. And so they come up with a list of the alternatives to cutting that they're going to try first before they self-injure. And even if it's 1 out of 10 times that they did something else, that's at least a start.
So let's assume that they are willing to take medication. I'll give you a moment. I'll come to you. Let's assume they are willing to take medications despite some challenges. Which medications probably would you think would be most suitable or work best with kids or adolescents who indulge in deliberate self-harm?
So this might not be a popular answer, but what I'll say is that in our DBT clinic, we actually de-emphasize medication because we have not found that medications significantly change the self-injury. So if there is a comorbid disorder, like an anxiety disorder or major depressive disorder, then we will treat that, so with an antidepressant, so SSRIs, or sometimes mood stabilizers like lamotrigine, right? Or even sometimes lithium if there's high suicidality. There is some evidence, it's not good, as in not strong evidence for naltrexone, thinking that that self-injury actually triggers the opioid system. And so if you use something in that category, that might help. And then N-acetylcysteine has also, for these kind of impulse control, it's, again, clinically, I've really not seen great results from it. So it's one of those where it sounds great on paper. I'm not sure it's great in actuality. But what I found to be most effective has been kind of actually using the DBT approach to kind of get the motivation, come up with alternatives in the moment. It's the mindfulness, recognize that you're in emotion mind, you're in that high state, and deliberately choose to do something else that you have predetermined that you will do instead of self-injury. So even if it delays it, that's still better than the kind of immediate engagement in that act. And that's a step in the right direction, but as you said, it's a long process, and sometimes it's accepting, and it's not black and white, either you're cutting or not cutting, but it's are we moving in the right direction in that even 1 out of 10 times you are trying something before you self-injure.
Dr. Chawda, what do you think about the treatment options for these kind of cases?
Well, I'll actually go with what she said. I don't think you can treat any person without some variety of psychotherapy, and dialectical is supposed to be one of the most used. But when we use medication, what I have found is naltrexone is one of the most, like you mentioned. There is some evidence for the usual anti-anxieties, but there's some evidence even for duloxetine. That apparently is now being used with fairly good results.
Duloxetine?
Duloxetine.
Okay. All right. Any other experiences about which medications are most suitable?
So we do look into the family history, and I have had a few cases where we've had family history of bipolar disorder when we dig into it, who come to us with cutting. And then in those patients, use of oxcarbazepine has helped in reducing the cutting behavior apart from other behavior issues. So there have been a few cases, but obviously we were not able to elicit any bipolar history in the patient. They were too young, but on the basis of family history, we tried using oxcarbazepine and that worked.
Okay.
Hello.
Yes, please.
I have 2-3 queries. One thing is about your one slide showed 40% ADHD.
ADHD.
Attention deficit hyperactivity disorder.
Right.
In the children.
People, they don't get treated.
Get treatment. So how you go about ADHD? Second thing is about most of our children and parents, they watch cartoons most of the times rather than mobile phones. And thirdly, about these 2 questions first. I wanted thirdly, yes, I forgot in there. But at least these 2 questions.
So we'll give you a moment to recollect the third question, and we'll probably answer the first 2 in the meanwhile. His question was that 40% of the people do not report for treatment as far as the ADHD is concerned.
I remembered the third question was about career choice, which creates a lot of anxiety amongst the parents as well as children. So when do you advocate to choose a career in USA?
All right. So we're going to have a tough time remembering the questions as well, just the way you did it. So first question is the ADHD group.
The 40% who do not get
40%
treatment.
who did not. So how do you manage
So
that?
it's been really interesting, and this is where the school consultation work has been very interesting. We've got, as the psychiatrist, I've gotten called in to meet with parents where the teacher has said, oh my goodness, this poor child definitely cannot attend. Parents are not on board, so they will not talk to pediatrician. They will not go to, they're scared to go talk to a psychiatrist. Will you just come in and educate this parent? And so surprisingly, I've been called in to do quite a bit of that, of just saying, let me talk through the pros and cons. And again, talk through the pros and cons of medicating and then pros and cons of not medicating. And so, so that's one way in which, again, we've been trying to increase the kind of access that kids have, because oftentimes it is the parent, because especially when it presents in younger kids, they're worried about all of the side effects and the problems. I mean, I think the other piece is, I really wonder what it's going to look like when, so if yoga is incorporated into the curriculum, right? And what we're also finding is that schools are starting to incorporate more universal interventions that are targeted towards inattention, because there's ADHD, but then also a lot of kids not diagnosed with ADHD who also have a hard time sitting still. So schools are starting to incorporate movement breaks, for instance. So I was sitting in a classroom, and the teacher, like clockwork, intermittently would have them get up and do some stretches and move, just to help them attend in the moment. And much more attention to executive functioning and helping kids start thinking about kind of how they're planning and going through the steps and trying to teach that earlier on. So kind of really trying to incorporate some of that, the more behavioral therapeutic pieces into the curriculum, so that they're learning it and they're getting it. And then unfortunately, those who don't get treated are high risk for substance abuse, especially as they grow up. Do I advocate any medications for ADHD? And so first line, we start with the methylphenidate. And I mean, what's really nice about treating ADHD that's different from most of our other psychiatric disorders is that when the methylphenidate is on, you know its effect. When it's off, right? So you don't have to wait 2 weeks. You don't have to wonder, was this other thing the thing that made them feel better 2 weeks later? And so what we'll do is we'll do it in collaboration with the school. We'll send a rating scale and say, before they start, they fill it out, so they know what the target of the medication is. And so methylphenidate is usually our first choice, given that the amphetamines sometimes have some mood some effect on mood. So we usually start with the methylphenidate, and then we'll have the teacher rate kind of post like medication trial, and to see if there's a difference. Because again, it's not without harm to medicate a young brain as well. And so we want to look and see what benefit there is versus what disadvantage or risk.
Do you use atomoxetine?
Yes, so it's not first, for true ADHD, not as first line. And it used to be that atomoxetine was, okay, so it's when you have an anxious child with ADHD, that's a nice medication to consider. I'd say that it's actually probably third line. So we start with the stimulants, so especially the methylphenidate. If that's ineffective, then we'll try the amphetamine salts. And then sometimes we'll augment with guanfacine or with the alpha-2. And then kind of third line would be atomoxetine, partially because it takes much longer, and so they don't have the patience to wait for it, but also from kind of the limited data that are out there, the efficacy is lower. And so, but we do absolutely.
Indian experiences on treatment for ADHD?
Unfortunately, we don't have amphetamines here. So methylphenidate is the first drug of choice if we decide to use medication. Atomoxetine comes as the second drug of choice, because we don't have amphetamines available here. Yeah. So, but I think apart from medication, I use a lot of occupational therapy in children with ADHD, because we find them having a lot of sensory issues. We also find that when we work with them on proprioceptive issues, their hyperactivity goes down significantly. So a lot of children where we just do regular occupational therapy sessions, most of the times we are able to avoid medication, and we use medication during the time of examinations, or that way selectively rather than continuously using the medication. So I think occupational therapy and behavior therapy and parenting techniques, if everything is put together, the use of medication reduces significantly for treatment of ADHD.
Any experiences?
Sorry,
Sorry.
I didn't want to interrupt anyone. moving away from the medicine, I just want to come back to what Dr. Mona and Dr. Kersey discussed about the attention-seeking component of self-harm. And I want to say that what I have seen is it may start out as a cry for help, but because of the attention they receive, you know, from their caregivers or peers, it gets reinforced into an unhealthy coping pattern. And coming back to these alternate skills, drawing from DBT, if you concur, Dr. Mona, there are some interesting techniques that I would like to share. So one is holding on to crushed ice, because it hurts you without harming you. Having a rubber band on your wrist that you can flick because it hurts you without harming you, and also drawing red lines on your wrist. Yeah? Okay.
Yeah, so and again, when I say attention, so I don't mean the attention seeking in any kind of a judgmental, negative way, right? It's a I'm in so much pain, I don't know how to help you understand how much pain I'm in, and then I'll do that, and then what happens is the environment will reinforce, because before they might kind of have some sense of what's happening, but then they see you self-injure, and then all of a sudden people will rally around you, and so then that behavior gets reinforced as this is how I get people to understand how much pain I'm in.
Yeah, and the same thing happens with the copycat behavior as well, because they see their peers get all this attention and special treatment, and it gets reinforced again.
Right, it's right. How do you get that? And so exactly. So there's actually, for the tip skill, the temperature component is a very popular one, and it solicits the dive reflex, which actually is a kind of a full parasympathetic response. And so when you're in this emotional sympathetic overload, it actually resets your system. And actually, so holding the ice in your hand, and sometimes even taking it and putting it on either side of your kind of like cheek area, but the full immersion, where we actually on one of our units for individuals with borderline personality disorder, so these are girls who self-injury was their go-to, and we actually, we would have a bucket of water, and they would fully immerse their face in this water for about 30 seconds, and it was really striking how that physical sensation was kind of enough to at least help them get out of that initial kind of immediate urge to self-injure. So again, it's coming up with a competing.
And now they're saying the same thing helps with symptoms of menopause. That's what I read today.
Okay. That was unexpected.
My question is
sorry,
to Dr. Potter.
Can I just...
Sure, please.
Sorry, for the ADHD treatment part, if none of those work, then clonidine is something that actually, surprisingly, a lot of pediatricians rely on clonidine more than psychiatric population, at least over here, what I've seen. But it really works in cases where nothing else is working, and that's something which we should...
Do you have any personal experience with clonidine?
Yeah, I have.
What is your feeling about it?
So the fear of the hypotension is more than the actual hypotension.
Okay.
So you can definitely monitor it, right?
Okay.
But I think it works. It does work. You want to add?
Yeah.
Age. I'm not sure.
So I think 12 is the cutoff, I believe.
So, because
right?
I would agree. So when I said guanfacine, so guanfacine and clonidine, you don't have guanfacine, but
same thing.
they're the same.
Same family.
Same family, and that's second line above atomoxetine for us in the States at least.
But like he said, what age would you think is it safe for you to start?
So I have seen pediatricians start 3- and 4-year-old children on and they sometimes will start clonidine first before they go to the stimulants, and so I've had the same experience with pediatricians, feeling very comfortable with it, and the right.
7.
So that's why they go to the clonidine, right?
So we've had very young kids, like 3 and 4, but 4 or 5, definitely they can take clonidine.
Okay.
But again, combined with behavioral and environmental interventions, right? Just to be...
He's got the first question, and then I'll come back to you. Yes, doctor, please go ahead.
Clonidine works better when you have kids with other disabilities like severe mental retardation or something like that, coupled with ADHD symptoms. Then there it works better. Yes.
My name is Dr.
It's
Sharad.
syndromic ADHD.
My question is to Dr. Potter. When an adolescent first time confronts that mom and dad are no more his heroes, they are no more wiser, and there are conflicts at home, home becomes a war room, everyone is irritable, and the great enthusiasm, curiosity diverts into addiction and alcoholism. And is this an area where antisocial behavior breeds?
Breeds.
Possibly, right? I mean, I think that if you have the vulnerability and then you have an environment that's not nurturing and in fact kind of models unkind or challenging behavior, then that vulnerability can get expressed more readily. So yes, I don't think that it's that every situation, so I don't think that it's going to cause that for every child who's in that environment. But again, for children who are at risk, then it might up the chances that, that some kind of antisocial vulnerability would come out. We know that, I mean, currently for conduct disorder, which is kind of the prequel to antisocial personality, is multi-systems therapy, right? It's not medication treatment, it's really kind of addressing the environmental factors and trying to provide kind of a more nurturing and containing environment. And so by that, you can, conclude.
Okay. Yes, Doctor.
I'm Dr. Marwale from Aurangabad. Dr. Mona has covered almost all aspects, but one area needs to be covered. So there are children who are in conflict with law with some psychopathology, particularly 16 to 18 years of age. So right from petty offenses, they may do some heinous offenses. So do they have psychopathology always? How often we are called for their evaluation, and what type of help that we can extend to such people? That's the question. Thank you.
Does anyone want to?
Yeah, Mona, it's for you.
It's for me. So I will say that that is not one of my areas of expertise. I'll still speak to it to the best of my ability, but but it's not necessarily the group of children that I have a great amount of experience with. Other than when I was working on the substance abuse unit. I think that oftentimes kids would come to me with a diagnosis of conduct disorder, kind of on their way to antisocial, based on behaviors. Again, just kind of doing things that seemed callous, unemotional. And there is a subset of children which, again, I don't know, I won't claim to have full understanding of, but kind of that do have kind of a callous, kind of unemotional type of conduct disorder, and that do have a greater tendency to go into the kind of the juvenile system. But that's not everybody who's in the juvenile system. And I think that there is this kind of this vulnerability factor, and the vulnerability leads to decisions that then put you in situations that get you in trouble. And then what I would notice with the kids who came to us is that people just judged them immediately. And so then they started living up to the judgments. And so while they were kids who kind of might have started with some kind of anxiety or depression, or even some kind of trauma or social kind of difficult family situation, their response were behaviors that were kind of more in the kind of antisocial realm. And so their narrative started getting written for them by the environment. So it becomes kind of an interaction kind of both ways.
In US, we read in the papers that many times children, they fire and kill many people. So such things do not happening in India.
Mm-hmm.
There are some heinous crimes like crushing a child in front of car. That was a news in paper in Aurangabad. So similar such things are happening in India also. So what is our role? That is my question.
In terms of kids who indulge in violent acts, as in the US, here we don't have as many violent acts, but there are different
What he's saying is that the kind of violence may differ.
Yes.
It may not be gun violence,
Yeah.
But
there are some other kind of violence. So if you see a child who's potentially violent or likely
What
to
do we
indulge,
do?
what should a psychiatrist be doing? Medicate the patient or some other treatment?
I think it depends on what's causing the violence. Again, the violence is like a fever. There could be multiple different underlying causes. It's a symptom of something, right? And so it's better understanding, because it could be that this is somebody who does have a hard time with ethical code and living in a society. That's one extreme. I think, but there's a whole other range of reasons why the person might be engaging. And some of it might be due to mental health issues, right? There might be kind of just but it also could be, I mean, there's a lot of gang violence that happens in the US, right? And so at a young age, they get kind of drawn into this kind of group of people to whom they feel very loyal, and then somebody from their group gets hurt, and then that basically leads to kind of this war between clans, and then violence ensues based on that. That's not necessarily mental health per se. So I mean, I think our role, I think, is in educating, partially saying mental health does not equate violence. So if you have a mental illness, that does not mean you're going to be violent, because I think sometimes that is the fear, that if you have mental illness, that you're at a greater risk of violence. I think there are a lot of people who commit violent acts who do not have mental health issues, and they're committing it for different reasons. Now, I think there are some people who do get into the legal system who have mental health issues who do need treatment. So again, it's on us to educate the public.
Anybody else would like to just add to that?
Just one question that has not come up today. The role of pets, domestic pets,
animal
in
therapy.
control of anxiety across all age groups.
Yeah.
Animal therapy.
Sorry?
Animal therapy.
Yeah, pet therapy.
So animal assistant therapy is a different story. Just the domestic pets, the role of...
Yeah, so even just a pet, it basically boosts oxytocin, which is the bonding hormone, will not alleviate anxiety. It's contrary or contradictory to anxiety to have the bonds which increase. So animal assisted therapy is used a lot in autism. We have it in our center. We use it and we've seen fantastic results, though we have not been able to quantify it. But having a pet at home is very useful for children with anxiety, with ADHD also, because there's a very strong comorbidity over there, which possibly is untapped. And just the social bonding also helps then in the social regulation. Because unfortunately over here, often the thrust is only towards academics and school behavior, whereas ADHD is actually it pans out in the whole quality of life for the child, and this definitely does help. It's one of the ways. There are many children who come and ask for pets, but parents, for obvious reasons, are reluctant to get a pet. And the dramatic change and difference is seen. And they ask for pets whom they can play with. A fish is not considered a pet in a child's mind. Yes, it matters.
So what exactly is it that you do for autistic kids at your center with regards to pet-assisted therapy?
So we have a trained animal therapist who comes in once a week and has sessions with the children. So we have 4 to 6 children who actually sit, and there are certain techniques of how initially they start just free petting, and then they play with them, then they would feed the child, and then the pet rolls over, then you have a ball. So different techniques, and initially there are children who would just sit in that corner and do absolutely nothing. If the dog is here, then slowly they would come, and then there are others who go all the way, all on top, because they need so much of sensory stimulation. There was one kid who almost crushed the dog because he was just so excited, So various responses to it, but it's worked well.
Incidentally, just so we know, there are actual pets who are trained as therapy pets.
Yes.
And there are some people now who encourage you to come and indulge in that kind of therapy with the pet. Some of them even bring the pet to your home if you request for it.
Yes.
So that is now an established form or a well-accepted form of therapy, although more so for kids, but also for adults.
Yeah, just as a matter of addition to everything that's been said, Dilkush, which is one of the nicer schools in Bombay, which basically deals with mentally retarded children. They have a dog who's the mascot of the school. They have a cat who's a mascot of the school, and they have a parrot who's a mascot of the school. And I suspect half the kids come to the school just to play with the bits.
So
Yes.
just to
Sorry.
continue with that, there are actually some airlines who have allowed autistic children to travel with their pets
With their
because it just keeps them so much calmer, and they are willing to accept that, which was absolutely unheard of, like even up to 5 years ago.
Incidentally, they even allow adults to
Adults,
travel.
yes.
I had to actually certify. There was
Yeah,
this.
but the animal has to be certified as a therapy
as a therapy
Therapy
pet.
dog.
Yeah.
As
So
a
that certification has to be acquired for how is a quagmire, but you had a question, doctor?
Hello. My name is Dr. Prashant. I'm from McLean Hospital. I have two questions, sir. Taking forward an interesting anecdote from Dr. Porter's talk, she said that anxiety is a gateway disorder to other psychiatric disorders. And there's one thing that our head of department, Dr. Nilesh Shah, says is that first there is obsessions, then that obsessions takes up the form of anxiety, which later when you modulate your life around that obsession, it becomes the form of phobia. And eventually it can become a delusion when your beliefs becomes too strong. So in this particular sense, it seems that at genetic level, everything is connected. Even psychosocially, everything seems connected. So do you agree with this particular aspect that he has proposed? And second question, it might sound a little naive, so I'm sorry for that. But you said that marijuana use actually causes decrease in the IQ points. And so far what I have heard through my 9 months of residency, because I'm a first year psychiatry student, is that IQ cannot be modulated. Basically you're born with IQ or something. So what I want to ask is that if marijuana decreases the IQ points, can modulation of cannabinoid receptors or something in some way be used to enhance the IQ points or something?
What was the first question?
Overwhelming question.
Oh, the gateway. Yeah. So anxiety is a gateway. So obsessions to anxiety, then you build your life around it, and it becomes almost a delusional kind of experience. So it's been interesting because I found myself, especially in my early days in working in our anxiety program, where I would get into arguments because it was so irrational. So somebody would sit and say, okay, if I don't turn the light switch 3 times, then something bad is going to happen to a loved one. And you try to argue, and there's no point in arguing because it's become such a fixed belief in there. And so absolutely, I have seen kind of that progression for where it just gets absolutely integrated. And there's some evidence for augmentation of SSRIs with atypical antipsychotics to kind of specifically target that kind of very fixed, almost delusional-like thinking that happens. Again, it's not necessarily psychosis, but there is something that happens in kind of how integrated it gets in the thinking. The second question was around marijuana and the IQ points. And so this is one where I'm quoting a study that I have not read in a long time. And so what they looked at I believe it was retrospective. So if you email me, I will find the study and send it to you. But they looked at cognitive testing at kind of various points in adolescence, and then again, kind of in the mid and late 20s. And what they did find was that there was a decline in by, I think it was 8 IQ points. And again, this is not saying that their core abilities have changed. It's saying that something about their kind of ability to think clearly has shifted. Now, it's a correlation, right? I mean, it's not a causal study. It's not kind of breaking it down into great detail. It's one of those where I think sometimes we take the liberty when we're talking with children to kind of get buy-in as much as we can, where we'll say that recognizing that science is imperfect, research is imperfect, and we have to take what we can get, recognizing that we need to do better in understanding what happens.
We'll have the last question for the day.
Yeah. There's some emerging literature to say that SSRIs do not work in adverse psychosocial situations. Now, question is in children, when they come with depressive symptoms in broken families or adverse psychosocial situations, of course, this is debatable, it's not accepted by everybody, but in your experience, do SSRIs work in those situations?
It's so much harder, right? And now we're learning about epigenetics, right? What we're learning, so Stacey Drury at Tulane has been doing a lot of this work where she's recognizing that their genetic, so when somebody experiences a trauma, there are genetic changes that happen as a result of that trauma that then get transmitted to offspring. as well, right? And so there's major impact of what happens in your environment on your biology. And what we do know is that some people are more vulnerable for that than others. And so, again, I think it's not fair to say it's a catch-all. I think that, and what we're also finding in kind of pharmacogenetic research is that even for people without trauma history or difficult psychosocial situations, some are more likely to respond to SSRIs than others, and some of it could potentially be chromosomal differences, right? Do you have the short allele? Do you have the long short? And so, so it might be that different factors will give you different vulnerabilities and different responses.
So what are our alternatives when we cannot use SSRIs in children and adolescents?
Sorry, say that again?
What is the alternative if we cannot use SSRIs in children, which is, I mean, practically it's only fluoxetine.
Alternative medications. So what's happened in the United States, for better, well, unfortunately, I think there's been a lot of talk about the overprescription of atypical antipsychotics, especially for children in foster care or kind of with this difficult psychosocial situations where basically when SSRIs don't help kind of quell the mood dysregulation and kind of the distress, the agitation, they'll get put on atypical antipsychotics. Because specifically what they've been shown in kids and adolescents to do is lower agitation and aggression. And so it's in some ways kind of saying we're treating the symptom, not necessarily what's underlying, recognizing that it's a very big task to really get to what's underlying, so you do the best you can. Again, it's very imperfect, but usually the second line has become kind of that atypical anti. So aripiprazole is probably one of the first ones we go to based on kind of the metabolic profile, although there's evidence that even though in adults it does not cause quite the weight gain, that in kids it does cause more weight gain, relatively speaking, so.
Okay, so we're already in extra time and yeah, sorry.
Just one point that I would like to add is that adverse events in early childhood, epigenetic changes, stuff like that. We also need to understand that there are more papers coming now on the role of SSRIs and other psychopharmacological agents that we use. They also have epigenetic reversing effects. Now, one of the most widely studied drug is an SSRI, which is fluoxetine.
Yes.
And it has got a lot of epigenetic modulating effects. So there are papers coming up where it acts as an antidepressant, fine, but it has also got an epigenetic modulation effect. Second thing, we need to look at drugs like SSRIs as not antidepressants, but drugs which change the kind of allostatic sensitivity that is there, right? So a person will not become happy, but a person will become less vulnerable to further psychosocial stresses. So we need to look at the changing roles of medications that we use.
And there is also some peripheral evidence about the neuroplastic effect of escitalopram.
Mm-hmm. Right. So there's an ongoing study at Mass General Hospital, which is our sister hospital, where they're in psychosis. They're looking at citalopram, actually, which is
citalopram and clozapine as well in psychotics.
Right, for kind of cognitive protection in patients with psychosis. And so, right, and again, I think you brought up the very important point that whenever I prescribe, it's setting reasonable expectations. This is not a happy pill. The goal of this medication is not to all of a sudden make you feel happy the majority of the time or even take you to happiness. It's to address the biology and decrease your sensitivity and your vulnerability factors.
Yeah.
And so it's really setting what reasonable expectations are for the medication piece of things.
Okay, so for paucity of time, we're going to allow just one last question.
Can I just, before you
end.
go to the last,
okay,
so it's just building on the fact that this is a person who doesn't have the stress resilience model, and all we are trying to do is sort of enhance that with the pill.
Stress
because they do not have the they don't have the innate resilience when exposed to a stressful condition, and what the pill does is builds on that.
Stress sensitivity is. Yeah.
Yes, good evening. I'm Dr. Darpan Shah from Rajiv Gandhi Medical College and Shivaji Hospital, Thane. 2 months back, I had 3 to 4 cases I was given in the OPD to take the history and make a diagnosis and treatment.
Just keep your mic closer to the mouth.
Okay. I'm audible now, sir?
Yeah.
The same question I had asked once in the conference held for the school psychiatry to Dr. Ajit Bhide sir, but we were very short of time for 2 minutes. So the same question I'm asking, how can we differentiate exactly between deliberate self-harm and true suicidal ideation, just as in adult patient, in a child or adolescent patient comes? Or can we misdiagnose, higher chances of misdiagnosis it? Or any risk involved in it, in history taking?
So the question is role of history taking.
How, exactly the same way we can correctly differentiate between true suicidal ideation and deliberate self-harm like we do in adults, in child and adolescent patients.
So the way we differentiate a suicidal idea and a non-suicidal deliberate self-harm, is history taking the only way of deciding whether the deliberate self-harm is suicidal intent or not a suicidal intent?
Yes. Yes. But is the same way in a child?
So is there a different kind of history taking in children and adolescents? And
maybe Dr. Kersey can respond to that.
Yes. Okay, it's a tough one. I'd say it's probably a combination both of history taking, which you mentioned, and actually the affect of the person who's done it. I think the level, we'd say most of us probably have found out that when you are, that when you take a person, you take the history of a person who's attempted suicide, by and large, about 60 to 70% of them have depression, which is severe enough to make them feel that there's no point in living alive and staying alive, and the only way out is to kill yourself. That level of depression, that level of despair, I think is much less in a non-suicidal, when you cut yourself, deliberate self-harm kind of thing. In addition to that, one of the things which I know makes a difference is the history of people who have attempted suicide in the family. If a person has attempted suicide in the family, which is very often found, it seems to point more towards the possibility of a little more aggressive suicide attempt. Because they haven't yet found the suicide gene, but they found as much as I think 20 or 30% of people who have attempted suicide will have somebody else in the family who's also attempted suicide, which is a huge percentage. History, I don't really know. I really can't answer your question. I don't know, maybe Mona.
No, exactly. It's looking at suicide risk factors. And then I'd say that in the kids that I've worked with, they're often hand in hand. And so the adolescents we're working with who are self-injuring often are chronically suicidal as well. And acts of suicide are actually often quite impulsive. So they might say that I've been having ideation for months, and then in the moment, there might be kind of a switch, and whether or not they actually act on that suicidal ideation depends on what means are right there. And so it's I think less black. I mean, what I found just clinically is that sometimes it's less black and white. But again, you might look at how they're talking about it. So in the moment, what was their goal? So I was feeling so distressed that because suicide is a solution to a problem. It's a permanent solution to a problem. So what were you trying to solve, and how were you trying to solve it in that moment? Were you trying to just make everything go away forever? Or were you trying to not feel what you were feeling in that moment?
Remember, the risk I had felt.
I think the whole point is, when you are not sure whether this is deliberate self-harm with suicidal intent or without a suicidal intent, please treat that as a potential suicide,
right,
irrespective of the age.
Because we are very bad at predicting, right? We are no better than chance at actually predicting who is going to attempt.
Irrespective of the age, this is the dictum. Suicidal, not suicidal, I can't make up my mind, treat that as potential suicide, full stop.
Absolutely.
Okay.
Yeah. Right. Just incidentally, I think there was a study which said that about 34% or something like that of people who have done deliberate self-harm go on later on to actually attempt.
But so that, right.
I think it's about 38%.
They are at high risk, right, they're at risk at a greater risk. So again,
so just do what Vihan says, treat it as a potential suicide. Let's not faff around.
Just 1 minute, please, sir. If the risk I had felt that if it's a pure deliberate self-harm case and not true suicidal ideation case, then in negative history, the risk factor is we can plant a suicidal ideation in the non-suicidal case, in deliberate self-harm case.
I think that's too, I think that's too generalized, and we are looking at possibilities and probabilities. Everything is possible. But the probability is that the person has come to you with a deliberate self-harm. And you want to figure out whether this is potential suicide or not potential suicide. That was your question. Treat that as potential suicide.
In the interest of not labeling that person as suicide, which is probably what you're trying to suggest, it's always good to err on the side of caution. Right? I mean, hindsight is 20/20, but that's no point. Once you've lost the child, you've lost the child. So it's always good to assume there is potential suicidality and treat it accordingly.
And never shy about asking questions regarding to self-harm and suicide.
Yes.
You're not going to plant anything in them.
Right.
Okay.
Either you are or you aren't. As simple as
To
that.
show it's much safer to ask the question rather than
Then
not.
to miss it. Then to miss it altogether.
The quantity of suggestibility in a patient who's potentially suicidal is much less than some other disorders. So saying, do you feel like ending your life, does not say, please go and end your life. Doesn't tantamount to that.
Thank you very
All
much.
right, great. So it's been a pleasure, and it's a test. We are way over time, so we probably will have some questions over coffee. But it's a testament to the quality of programs that Dr. Vahia organizes, and also a testament to the fact that we have a brilliant plenary here who has so much of collective wisdom and is more than happy to share it with you. And we are already into overtime, and we are still
It's
not
also
out of
testimony of
questions.
the interest and the caliber of the participants who are asking such interesting questions.
I was just about to say that. You preempted me. And of course, all of you being here today and making this interactive session so exciting and so colorful and so interactive. So it's a big thank you to all of you, a big thank you to all the panelists, and above all, a big thank you to Dr. Vahia to bring us together again and again, and every single time surprising us with an even better program than the last time. So thank you so much, sir, and we hope that you keep doing this, and we keep learning from you and from everybody else here.
If I knew, then I would do a monologue. It's not me, it's me learning from you.
You scratch my back, I scratch yours.
Sir, any comments?
Any closing comments from the panelists?
So, I can keep on saying thank you, and each one of us keep thanking each other, but something that for which you will really want to thank me is that dinner is already laid out. And the dinner will be open till 10 o'clock. At 10 o'clock the dinner will close. Tomorrow morning, 8 o'clock breakfast, 9 o'clock we start the session. Please be in the hall by 9. And sirs and madam, I'm honored to have you here, and thank you for making it so much a learning experience for all of us. Thank you.